Yeah, Vijitha, please.
Good afternoon, everyone. I'll try to be quick. So, over the next few minutes, we'll go through a brief overview of the causes of proptosis in children and identify some markers which would potentially herald some sinister etiology. So, we all know that proptosis in a child can be as a result of infections, choristomas or hematomas, vascular malformations, inflammations, primary neoplasm, metastatic lesions, or systemic leukemias and lymphomas. We'll be looking at case presentations which broadly cover the neoplastic and tumor-like conditions. So here's the first case scenario. 2-year-old girl presented with swelling in the left eye for about a month, and she had been treated as orbital cellulitis elsewhere with systemic antibiotics. However, the swelling progressed and she went on to develop proptosis in the last week. On reviewing the history, there was no history of trauma or upper respiratory tract infection, and this is the clinical picture that we see. There was a well-defined lower eyelid lesion along with abaxial proptosis and superior globe dystopia. So, labeling a child with orbital cellulitis does not end it there. It's always important to identify the cause behind it. And whenever you cannot attribute it to a focus of infection such as eyelid infection or a style, it's very important to perform an imaging. So, the MRI in this child showed a well-defined lesion in the anterior and mid-orbit causing lobe indentation, and it pushed the orbital structures medially. The flag number 2 is that in a child presented with rapidly progressive proptosis with inflammatory signs, do not forget to rule out rhabdomyosarcoma. She did well with an excisional biopsy that confirmed the diagnosis as well, followed by chemotherapy and radiation. So another child, a 5-year-old boy, presented with prominence of both eyes since 6 weeks associated with eyelid swelling. There were no other ocular or systemic symptoms. This is what we saw. There was bilateral mechanical ptosis and proptosis. And on imaging, there was ill-defined diffuse homogeneous isodense lesions in the superior orbit, which extended up to the apex. On systemic evaluation, there was low hemoglobin that was noted, but there was no there were no atypical cells in the peripheral smear. Interestingly, the incisional biopsy showed dense sclerosis and polyclonal inflammatory infiltrate, suggestive of a non-specific orbital inflammatory disease. So, in bilateral orbital lesions in a child, always rule out systemic causes through a thorough evaluation, and NSOID is a diagnosis of exclusion which can occur even in children. They usually tend to do well with steroids. The third case scenario is that of a 9-year-old girl who presented with a sudden onset swelling in the right eye which progressed over 1 week. She also gave history of generalized weakness and malaise. On clinical examination, there was gross proptosis with inferior dystopia. On imaging, there was a large, ill-defined, irregular lesion occupying the superior and lateral aspects of the right orbit in both intraconal and extraconal spaces. A scalloping of the orbital roof was also noted. So a high index of suspicion was kept for leukemia, and peripheral blood smear, however, did not show any atypical cells. So a debulking was performed, and the histopathology showed features of a malignant round cell tumor, which also showed Fly1 positivity. The bone marrow biopsy, along with the immunophenotyping, confirmed a diagnosis of T-cell acute lymphoblastic leukemia. She went on to do well with chemotherapy. So in rapidly progressive orbital lesions in the presence of systemic symptoms, it's very crucial to rule out hematolymphoid malignancies. This can be done through a biopsy and with a peripheral blood smear and bone marrow biopsy. So here's an interesting case of an 8-year-old child who presented to the emergency with sudden onset proptosis of the right eye and also accompanied by vision loss. He gave history of trivial trauma that could not be attributed. The vision in the right eye was hand movements. There was proptosis with inferior displacement of the globe, limitation of movements, and grade 2 RAPD. This was what the fundus picture showed with retinal edema and a central cherry red spot suggestive of central retinal artery occlusion. An ultrasound of the orbit showed a hypoechoic lesion with causing significant pressure on the globe and optic nerve. CT confirmed the presence of an orbital mass lesion. And in view of the central retinal artery occlusion, an ocular massage with IOP lowering therapy was administered, followed by a paracentesis. She was then taken up for orbitotomy, where the lesion was noted to be very irregular and non-encapsulated. On histopathology, there was a fibromuscular and fibrofatty background with proliferating blood vessels of various sizes lined by plump endothelial cells. And these endothelial cells stained positive for CD31. In the background, there were a lot of eosinophils, thus establishing a diagnosis of angiolymphoid hyperplasia with eosinophilia. On systemic evaluation, even peripheral blood eosinophilia was also noted. The proptosis resolved with oral steroids, but there was no improvement in vision. So presence of loss of vision in a child with proptosis warrants immediate intervention. Vascular malformations are the ones which usually cause this picture, but any tumor, even benign ones, which can cause a mass effect, can result in vision loss. Now, a 5-year-old child presented with bulging of the right eye associated with pain, redness, and watering. He actually had an enlarged right eye which was causing the pseudoproptosis, but there was no perception of light in the right eye. On a close examination, there was corneal clouding with hyphema in the anterior chamber and a fixed dilated pupil with a hazily seen cataractous lens. Since there was no view of the posterior segment, a B scan was done, which confirmed the presence of intraocular tumor with calcification suggestive of a retinoblastoma. MRI confirmed the presence of the same, and there was no extraocular extension. So this child underwent an enucleation with implant and adjuvant chemotherapy later on. Whenever there's no view of the posterior segment in a child with proptosis, a B scan is mandatory. It's important to remember that retinoblastoma can present as aseptic orbital cellulitis in advanced stages. Moving to the last case of this set. A 5-year-old child presented with protrusion of the right eye in 6 weeks, and there were no associated features. So there was inferior globe dystopia, and this was the computed tomography showed. There was an expansile lesion with the epicenter probably in the greater wing of sphenoid, but the lesion also involved the lesser wing and the body of sphenoid. There was also adjacent soft tissue involvement. That was not it. There was another expansile bony lesion involving the frontal bone with a small soft tissue component to it. So expansile bony lesions and with adjacent soft tissue components should point towards histiocytosis. In this child, the only parts that were involved were the skull. So an incisional biopsy was performed from the orbit to confirm the diagnosis along with a steroid injection. And she subsequently received chemotherapy because of the multifocal nature of the disease. So in lytic bone lesions, consider histiocytosis. Always evaluate to look more throughout the body, because presence of systemic involvement, all multifocal disease warrants chemotherapy. So I'll conclude by saying that tumors like RB and rhabdomyosarcoma can present like orbital cellulitis. Bilateral orbital involvement is seen in leukemias and NSOIDs. Systemic symptoms should alarm you for hematolymphoid tumors. Vision loss can be from optic nerve tumors or due to a mass effect. RB can also present as a painful blind eye. And in lytic lesions, think of histiocytosis. Thank you.
Thank you, Vijitha. Sorry we had to rush you with your presentation. And thank you very much for being there. And sorry to the next speakers, we took extra 5 minutes.